welcome back everybody. Today we're going to talk a little bit more about actual control of blood pressure. Last show here we discussed a lot about really the different factors that are going to influence influence blood pressure, those things that were physiologically regulated as well as things that were not. Today we're going to look into a little bit more of short-term and long-term control of blood pressure, looking at things like nervous control, certain reflexive actions, as well as kind of some of this longer term control in terms of kidneys and some of the factors both neurologically as well as hormonally that are going to influence this. So again, if we look at overall at what was regulating blood pressure, you can see the figure I put on here. Mean arterial pressure, again, that overall average pressure on the blood it's a combination of a number of different things. We kind of said it was a three-layered kind of system of regulation here. One of the things I talked about first was this one right here. How is the heart going to work in terms of acting as a pump and how that's influencing cardiac output. And then those things that influence cardiac output, such as heart rate and stroke volume, we're going to play a role in mean arterial blood pressure. In terms of peripheral resistance, the diameter of those blood vessels, vasoconstriction versus vasodilation, again, going to play a role in this. The other thing that we discussed, and I just mentioned it, and we'll go into a little bit more detail, is how this can get involved, is this idea of blood volume. Blood volume, again, regulated mainly by fluid loss, and that it's a lot of times in the kidney. I mean, we're going to lose fluid certain ways through sweating, through breathing that we can't really control, but physiologically we're going to really try to maintain that with the kidneys. We can also take in other fluids. The other thing is we can mobilize a little bit more blood, and this is one of the things that we can do by doing some venous vasoconstriction. We can get some of that blood more available, so we talked about before. And this is one of the things I didn't really mention before, but this is another way we can bring blood pressure up and increase that venous return, is by actually getting a little bit more vasoconstriction taking place in the veins, mobilizing more of that reservoir of blood that we have. So regulation of blood pressure is going to be a combination of a number of different things. Really, when we start looking at what is really doing the vast majority of regulation of this, it is going to be that region of the brain that we talked about a number of times as being a vital center, which is the medulla oblongata. It has a vasomotor center. It also has a cardiac control center. One of the things that we're seeing is a very quick-acting reflexive action, and one of the things I'll talk about first here is this idea of the baroreceptor reflex. We will see that we do have baroreceptors, which are pressure receptors, in the aortic arch, up in the actual carotid, starts of the carotid arteries, these areas of these elastic arteries. They can detect changes in that stretch, which is going to indicate more pressure if there's more stretch. And again, going to feed back up to this medullary center here. And we're going to see through the sympathetic or the parasympathetic nervous systems, we can regulate somewhat what would be going on with the heart in terms of output, as well as the vasomotor center. So just kind of walk you through the baroreceptor reflex. Like I said, short term, we're doing a lot of pressure reception here. And again, when it's saying short term, what this is really meaning is that when we start thinking about blood pressure, anything that's happening with the vasoconstriction or vasodilation, anything that's happening with cardiac output, in reality, these are short-term compensations. And what I mean by that is if that heart rate changes, the corresponding influence it was having on pressure is going to change. Same thing with vasoconstriction or vasodilation. If we are vasoconstricted and we then vasodilate, the action that is having is going to go away. Really, the only way to long-term influence blood pressure is to get more blood into the system or more blood out of the system to make these long-term changes. And we're going to see that is really where the kidney gets a lot more involved. But short-term, we're going to measure this pressure in these baroreceptors. Long-term, we're going to be looking at the kidneys and it measuring some pressure in order to do its job. And along the way, it's going to be influencing a lot of blood pressure factors. Again, cardiac output, we talked about before. And really, when we look at mean arterial pressure, it is that pressure is the kind of the combination of cardiac output and that peripheral resistance. Again, how we are actually controlling cardiac output is through either sympathetic action on the heart that would increase the heart rate, increase the force of contraction, or parasympathetic, which would decrease the heart rate and not influence that force of contraction, but let it go back to normal. Total peripheral resistance is going to be really that vasoconstriction, vasodilation of the arteries and veins and arterioles and venules. So those baroreceptors, like I was saying, are really in that aortic arch, in the branches that are going to be in the carotids here, really stretchy regions of elastic arteries, and because of that, they can be very good at being very sensitive to changes in that pressure. You can kind of see here an increase in pressure. This is kind of showing you a nice little feedback loop here, what we could do if pressure was getting high. So if pressure was getting high, increase in blood pressure, we're going to see increases in that baroreceptor signaling, saying, okay, we are recognizing more pressure here. That is going to get sent to that control center in the medulla. And one of the things it's going to do is decrease sympathetic output. So again, sympathetic output means less norepinephrine released. We know, at least on the arterioles, that is going to lead to increased vasodilation, which will decrease peripheral resistance and in and of itself would drop blood pressure. But the other thing this is going to do is act on those beta-1 receptors in the heart to decrease heart rate through the SA node and AV node, as well as to decrease contractility, again, through the action of those beta-1 receptors. Both those things would decrease cardiac output, which would also drop blood pressure. Parasympathetic output and muscarinic action on the SA node is also going to help to decrease that heart rate. All those things together would drop blood pressure. And again, that change in pressure is going to be, again, being monitored by those baroreceptors. So this loop is going to feed back on itself. And again, if we are still getting too much stretching, we'll try to continue this as a way to short-term downregulate blood pressure. Again, we could do the exact opposite on this one, and I don't remember if I have a slide for this or not, but we can do the exact opposite. If blood pressure was too low, we would get decreased firing, and you would see increased sympathetic output, decreased parasympathetic output, which would increase peripheral resistance and increase cardiac output, which would increase blood pressure. So we can do the opposite effect if the pressure is getting too low. And that actually is the one right here. So mean arterial pressure, if you stand up from, let's say, laying down, all of a sudden you're going to get a decreased firing on those baroreceptors. Again, goes up to that cardiovascular center. And this time we'll do the exact opposite of what we did. We're going to increase that sympathetic output, which is going to act on the heart to increase the force of contraction, increase the heart rate, which will increase cardiac output. It's also going to, through the vasomotor center, going to act on those arteries and veins, increase vasoconstriction, at least in a lot of areas, increase that peripheral resistance. All these things are going to help try to bring that blood pressure back up. And again, we'll feed back up, and if it's in the right range, we'll stop doing these actions, or at least maintain them at the level they're at and not continue to increase them. There is other receptors. So like I said, they're the coronary arteries. They actually have some as well. Respond to arterial pressure, like it says there, a little bit more sensitive, making sure the heart's getting enough. There is some in between the, like it says there, venoatrial mechanoreceptors. So looking at changes in that central blood volume. So if you're laying down, sitting up, those are going to be activated. There's also some mechanoreceptors that are dealing with stretching of the heart, and those things can also influence a lot of this. Again, don't want to get into all these different receptor reflexes. But you can see here a number of different mechanoreceptors and baroreceptors that are present on the heart. We also have some other receptors that can influence this. So there's chemoreceptors in the heart. If you're not getting enough oxygen, these can release a number of hormones that are going to try to get more blood flow going to the heart, cause pain in response to that lack of oxygen. So those are some things that can be activated within the heart. Also different chemoreceptors, where if you're getting too little oxygen, so like it says there, hypoxemia, hypercapnia is too much CO2. These are things that are a lot of times involved with breathing, but if those numbers start getting really bad as well, it will try to increase cardiac output to get increased flow to the lungs to and bring about a better exchange of oxygen and carbon dioxide. So as I was saying, everything on this side is really that more short term. So we were talking about kind of these short term actions. We can increase heart rate, we can increase stroke volume, which would increase pressure. We can increase vasoconstriction, which would increase pressure in those arteries. We can increase venous constriction here and bring about an increase in pressure that way as well. What we haven't really had a chance to do is really talk about this little part here, how it's regulated with blood volume and what's going on with the kidneys. But one other thing to kind of point out here, we talked about reflexive actions on a lot of this. In terms of that vasomotor, there is a number of substances, and again, I don't want you to memorize this list. This is just kind of, again, pointing out there is a number of different vasoconstrictors as well as vasodilators that endocrine action-wise are going to be very involved in blood pressure regulation of the body. So we've talked about norepinephrine already. We know this is going to go through sympathetic neurons, can act on the heart, can act on those different blood vessels to lead to vasoconstriction. You can see there is a number of the rest of these here. This vasopressin is actually ADH, is another name for vasopressin. At high levels, this can actually act as a vasoconstrictor as well to increase blood pressure. We're going to talk in a little bit about angiotensin II as being a vasoconstrictor as well. You can also see there's a number of these that are going to release, cause vasodilation or vasorelaxation. Nitric oxide is one of these ones. Viagra, for example, is actually why they thought it was going to be a good blood pressure med. It was actually a nitric oxide reuptake inhibitor, which would lead to increased vasodilation. A little bit later on, we'll talk about atrial natriuretic peptide. It is another one of these that is going to help with that vasodilation. We know acetylcholine, through the action of the parasympathetic nervous system, neurowise, can act that way. And again, there's a few other ones, things like bradykinin, histamines. These can act as vasodilators locally, in some cases more systemic in others. One of the other things we're going to see is if we're not getting strong enough blood flow to the brain, this is also going to act as a reflex to really increase blood pressure to make sure we are getting it there. So if you start getting loss of oxygen or loss of flow, so that medullary ischemic response, that is going to increase cardiac output, increase activity in the vasomotor centers to increase cardiac output, as well as lots and lots of vasoconstriction, which is going to try to bring that blood pressure up to make sure we continue to perfuse the brain stem. Other things, obviously, being stressed out, being angry, all these things can influence blood pressure. As I was kind of saying, and I got a little bit ahead of myself on that one, the other thing that we need to really kind of address is long-term, how do we really kind of bulk change the set points on blood pressure? So how do we long-term control this? And really what this is going to be a manner of is it's really altering the actual amount of blood or water in the blood vessels. And we do this by either a couple different ways. We can bring in more water, we can release more water. The other thing that tends to play a big role on this is where we move sodium. So if we move sodium out of the body, water tends to follow. If we retain sodium in the body, water also tends to follow that. So we're going to see that there is a few different hormonal actions that are a lot of times either triggered by the kidney, the brain, or the heart that can bring about changes in this overall blood volume. Again, we mentioned before, increases in blood volume will lead to increases in blood pressure. If we have this, sometimes, like I said, if pressure is getting too high, the fast response in the short term would be to compensate for it with the rest of the cardiovascular system. So we talked about this already. If we get pressure getting a little bit too high because blood volume is too high, we could compensate by decreasing cardiac output and vasodilating more to bring that pressure back to normal. What we're going to kind of worry about now is how would we compensate with the kidneys for a longer term change. Because again, if we decrease cardiac output, but we don't change blood volume, as soon as that cardiac output goes back up or the vasoconstriction comes back a little bit, pressure would go back up. So really the only way to long-term change this is to actually get rid of the fluid here by excreting more fluid in the urine, which can drop the blood volume, which will bring the pressure back to normal, but then it is also decreasing this. So that is a long-term solution if pressure is too high. Again, opposite effect if pressure was getting too low. One of the ways we do this, and this is a crazy flow chart. One of the ways we do this is what's called the renin-angiotensin system. It is this crazy middleman involved intermediary to another intermediary type of thing. One of the things that we need to realize is the kidneys, in order to do their job, need a particular blood pressure. They are making a blood filtrate by having increased pressure at the kidney, pushing fluids into the kidney tubule system, and then modifying those fluids to create our urine. If you don't have enough pressure, you don't make a filtrate. If you have too much pressure, you're going to be pushing things into that filtrate you don't want to be there. Things like protein, sugars, other stuff like that that you don't want to be part of the urine. So the kidneys are highly involved in regulating pressure systemically so they can do their job correctly. One of the ways they do this is when there's part of the kidney tubule that goes close to where the filtration happens. This is called the juxtaglomerular apparatus. We have blood flow going past there. If pressure starts to drop too low, you're going to get reduced flow past there. And what these cells in this apparatus can do is they can release a substance called renin. It's a hormone. It's an endocrine hormone. One of the things that's present in the blood is this protein called angiotensinogen. Again, we talked a number of times about those prohormones, those things that ended in ogen, anything like that. It's an inactive form. We'll see when we get to digestion, we'll talk about pepsinogen. It's an inactive form of pepsin, for example, is another one of these ogens. This renin is going to activate angiotensinogen to angiotensin 1. And it seems like that should do something. It really doesn't. What happens with this one? This angiotensin 1 gets triggered here. What's going to happen is we have cells, it's mainly in the lungs. These are these angiotensin converting enzymes that are present in the cells of the lungs. It's in other tissues as well, but the main thing, all the blood does have to go through the lungs, and that's one of the reasons they think it's high in that area, is pretty quickly all the blood goes through the lungs. So this is the best way to have those cells convert that angiotensin 1 to angiotensin 2. Angiotensin 2 is a vasoconstrictor. So if pressure was getting a little too low here, this is going to lead to vasoconstriction, is one of the things it's going to do. Vasoconstriction in the arteries, vasoconstriction in the veins. That's going to increase preload, increase that afterload. Both those things would increase blood pressure. Again, the enzyme right here, they gave it a really simple name. It's angiotensin converting enzyme, which would be in the middle right here. A lot of times they call that ACE. If any of you that have actually been in the hospitals, like the nursing students or stuff like that, you might have heard of ACE inhibitors. That is a blood pressure med. ACE inhibitors, these are enzymes that are going to actually reduce the conversion of that enzyme. The other thing that angiotensin 2 does is it increases the release of aldosterone from the adrenal cortex. If you remember, aldosterone was one of those mineralocorticoids. That mineralocorticoid, what it does is it actually causes the kidneys to increase the reabsorption of sodium. If you increase the reabsorption of sodium, it means water is going to follow that. So if you increase water reabsorption, you're going to increase blood volume, which along with that vasoconstriction everywhere is going to increase that preload. And again, we know those two things together here are going to increase blood volume overall and therefore increase pressure. The other thing that can happen hormonally, and this is another one we've talked about a little bit before, antidiuretic hormone or vasopressin, which is a posterior pituitary hormone. When blood pressure starts to get a little bit low, if we release vasopressin or ADH at really high levels, it is a vasoconstrictor. One of the things it does at a little bit lower levels is it acts on these kidney tubules and makes them reabsorb water in areas that they normally wouldn't be. So again, increased vasoconstriction along with increased fluid absorption is going to increase blood volume, which is going to overall increase pressure. One of the things that hormonally acts in the opposite way of pretty much aldosterone is atrial natriuretic peptide, or atrial natriuretic protein, ANP for short. This is what happens, the heart will release this when the preload is actually getting to be a little bit too much. It's overstretching the atria of the heart. What this does is it acts on the kidneys to have them stop reabsorbing sodium, let more sodium become part of the urinary filtrate. What this means is more water stays in there, because again, the water tends to follow the sodium. And what this is going to do is decrease the reabsorption of water at the kidneys and therefore increase urine output. If you get rid of more water, you are going to get rid of more blood volume. That drops your blood volume, which will drop the pressure. So again, just to kind of give you a little bit of a summary of this long-term blood pressure control, a lot of this is mainly hormonal, acting on the kidneys to actually change the reabsorption of water at the kidneys. The other thing that happens that I didn't really mention here, but if pressure is higher, you're going to increase renal filtration. So pressure natriuresis is very simply higher pressure means higher filtration. If you have higher filtration, it means more blood volume loss. One of the things that can happen if your blood volume is not at the correct levels is you can have what's called shock. This is that physiological problem where you're not getting enough pressure to actually perfuse your tissues. If you've ever given blood and got a little faint before, it's kind of a little mini example of that. Like I said, if you're going into shock, you a lot of times will get kind of confused. You'll get that tunnel vision a little bit. You kind of get cold and clammy, kind of sweaty. Your heart tends to speed up to try to make up for that. If you would actually feel your pulse, you won't feel a strong pulse pressure on that one. It'll be a lot weaker a lot of times. This can happen in terms of shock for a number of different reasons. The first one is, to me, the most obvious one, hypovolemic shock. Hypovolemic shock is very simply you don't have enough pressure because you don't have enough blood volume. You have lost blood volume through some type of way. The most obvious one is hemorrhage. So you had a big injury, you're losing a lot of blood. That would give you hypovolemia, which is, again, sooner or later you lose enough blood, you go into shock because you don't have enough to maintain that pressure. Other ways that you lose a lot of fluids, things like diarrhea, vomiting, those are also going to long-term can lead to that hypovolemic shock if you lose too much fluids. Other ways we can have this is septic shock. So certain bacterial toxins sometimes can lead to systemic vasodilation, and we've said a number of times you actually don't have enough blood for all your vessels to be open all the time. If they do that, it will put you into shock. That's one of the examples of septic shock. Cardiogenic shock, the pump stops working, very simply. And then finally, anaphylactic shock is that allergic reaction where you're getting some weird vasodilations due to allergic responses, things like bee stings, for example. As humans, we can do pretty well with a decent amount of blood loss. If you give a pint of blood, a pint of blood is a decent amount of your blood supply. You can give up to a pint or two and generally cannot have particularly serious symptoms. Every once in a while you'll have a response where your body kind of overreacts to it a bit. But if you lose 10% or less of your blood supply, the body very easily can usually compensate for that. Even up to 30% of your blood volume. So let's say, like we said, 4 to 6 liters. You could lose 2 liters of blood, which would be like 4 pints of blood. Generally, that is survivable. What you're going to see is once we start getting past that, greater than 30 to 40% of blood loss, that's where you're going to have trouble with the body starting to have enough to perfuse other things here. The other thing we see on this is the body is generally going to try to compensate until it can't any longer. So, and I mentioned this a few times in class, that's where if you're looking at somebody's numbers, when somebody crashes, usually numbers are good, and then it's drop way off. That tends to happen because the body will compensate through increased cardiac output, increased vasomotor activity, all these things to try to keep those things within normal numbers. And when the blood volume drops too low, it loses that ability to compensate, but it will speed up the heart and speed it up until there's just nothing else it can do. So that's why we generally see normal numbers and then a crash, not this slow decline where it gets worse and worse. Again, compensated hemorrhage is, again, heart rate is going to increase. We're going to get increased releases of vasoconstrictors, that rapid breathing to help with the respiratory pump. All these things to try to mobilize more blood. If you can't compensate for it, that's when we get that crash. Last couple things with this, generally resting blood pressure, and this number's changed over time. Now they generally say if you're consistently 130 over like 90, that is considered hypertension at this point. A lot of times it's kind of that low grade hypertension. They will pay attention to it, but the main thing is hypertension over time can lead to long term. It can lead to congestive heart failure, where that heart needs to keep getting stronger and stronger to pump the blood against that increased pressure. And as it does that, it has a tendency to lose its flexibility. The other thing that hypertension can do is cause damage to these really small arteries and lead to aneurysms, which are just a breaking of a artery. Hypotension, again, not quite as common. Most people, this is a low resting blood pressure. A lot of times, certain people are just have that a little bit more common with them. Obviously, other ways this can happen if you are dehydrated, you've lost blood. Those would be another examples why you'd be hypotensive. As you get older, one of the things we're going to see is, I've said this a number of times, things tend to lose their elasticity. So when this is happening over with age, those arteries become less and less flexible. So what this really means is generally with age, you're going to have an overall increase in systemic blood pressure as you age. Part of the reason that high blood pressure is also tends to be something that's a little bit more of an issue as you get older. Again, just showing you where those chemoreceptors and baroreceptors are at. And really the last thing I want to talk about on this show is just, and it's not really with the blood pressure as much, but really not a good spot to put this one. But one of the things we're going to see is with this vasoconstriction, vasodilation, and changes in pressure, the body is going to do a very good job about trying to divvy up that blood flow where it needs to go and when it needs to go there. So, for example, if you're sitting on the lazy boy, having a beer like this guy looks like he happens to be doing on this one, you're going to increase your blood flow to your intestines. You're going to increase blood flow to the kidneys. Because you're not using that skeletal muscle, you're not going to see a lot of flow to the legs. Where if you were playing soccer or playing some other sport, you're a lot of times going to see a big increase in blood flow to those active muscles and a decrease in other areas. So to kind of show you this with this graph, this is kind of one of my favorite ones here, kind of showing you at exercise versus at rest. And you can see at rest, your main, like almost half your cardiac output in terms of areas it's going to, you can see it's the kidneys and the digestive tract. You can see it's 22 to about 27% of that overall cardiac output. Overall, in the amount of blood flow that's going there, still pretty consistent. You can see muscles get some, but not nearly as much. And then as you look at the rest of these, you can see it's kind of divvied up there. So at moderate exercise, one of the things to kind of point out here, the percentages are going to change a little bit. The overall output is actually now a little over 3 times what it was at rest. So we're going to see here the percentage going to the muscles at exercise is a much bigger percentage, and the overall volume is gigantic. It's actually more than the whole output of the heart at rest. So this one here would be 12.5 liters of the 17 are going to the muscles. You're going to see in the actual numbers, and especially in the percentage, blood flow to the kidneys and the digestive tract tends to go way down. You might kind of go, okay, the brain's getting less. Actually, the brain almost always gets its share. It's a lower percentage because there's a greater amount of output, but if you're looking right here, it's actually more blood going to the cerebrum than there was at rest. And the other thing you can see is another one that really gained a lot more volume was the skin. And again, it has to do with the fact that if you're exercising, you're going to be generating a lot of heat. If you're generating that heat, we need a way to dissipate it, so more blood flow is going to be going to the skin. And the other thing you can see is, even though it looks small here, it's about the same percentage. You've actually increased the blood flow to the heart about almost 4 times, 3.5 times over. So you can kind of see blood is going to get sent where it needs to go at any particular type of activity. All right, so I will see you next time.